afternoon, and welcome to the American Lung Association's Quality Improvement webinar on conducting spirometry during and after COVID-19. Hello, I'm Jill Hines. I'm the National Director of Lung Health for the American Lung Association. Before we begin, just a few housekeeping items related to this particular webinar platform. At the bottom of the screen, there are multiple application widgets that you can use. All of them are resizable and movable. There is a resource widget, and you will find a variety of resources that you can download or print from that resources widget. For the best viewing experience, we recommend that you use a wired internet connection and close any other browsers or programs that you have running in the background. Please use Google to access this webinar for best results. And also, if you're using a VPN, please close that as well. For best audio quality, make sure your computer speakers or headsets are turned on and the volume is turned so you can hear the presenters. If you have any technical difficulties during the webcast, please let us know using the Q&A box at the bottom of your screen. We'll respond to you through that Q&A. It looks like an email server or email box. This webinar is going to be very interactive, and we encourage your questions. So please submit them in the Q&A box. For example, if you have some patients that you're considering to do spirometry on and you want us to address that case study, please include it in the Q&A box. We are scheduled for this webcast to be 60 minutes. However, if we have a large number of questions from our participants in the Q&A box, we do have the option of going slightly longer. This webcast is being recorded and it will be available tomorrow, and you can use the same link that you did to access today in order to see that recorded webinar. Throughout today's webcast, we're going to be using polling. And so we're going to do that one right now as a trial run. So on your screen, you're going to see the first question. How is your practice currently conducting spirometry testing? Please click the one that's appropriate for your clinic. We are currently conducting spirometry as normal. We are not conducting any spirometry test. We are conducting spirometry outside, for example, in a tent. We are only testing essential patients, or you do not work in a clinical setting. Please go ahead and click the circle that relates to you and hit the submit button. And let's look at the responses now. Currently, we have about 14% that say they're doing spirometry as normal. 50% are not doing spirometry at all. And there's about 36% that are only testing essential patients. Thank you very much. As we move into the next slide, I would like to introduce our faculty today. Ed Corazala is the Technical Director of the Pulmonary Lab at the University of Minnesota. He teaches basic and advanced pulmonary function interpretation for the Pulmonary Residency and Fellowship Program at the at the University of Minnesota. He received both his undergraduate and graduate degrees also from the University of Minnesota. I guess Ed started at the university, loved it, and didn't leave. Ed has numerous publications and is currently involved in multiple research studies. He has long been involved with the American Lung Association as a faculty for us, and we're excited to have him today to lead our webinar on conducting spirometry during and after COVID-19. Ed, I would like to turn all controls over to you now.
Good afternoon, ladies and gentlemen. This is spirometry during COVID. We're all wearing complete PPE, face shields, N95s, gloves, gowns. We're wearing a surgical mask over our N95 because of the huge shortages of the N95s, and so that we don't run out of them for our COVID wards. Spirometry, I don't think spirometry will ever be the same. When I talk to my infection prevention people, they go, well, you never wore masks before? And the patients for aerosol generating procedures? And I'm going, well, no, actually, we've never worn masks before. We're getting a lot of confusing guidance from all different parts. And the reason why this whole COVID, we've never done spirometry during a pandemic before. Things are changing very quickly. What PPE we can use depends on our availability. Different groups, even our governor bodies like the American Thoracic Society and the European Respiratory Society have inconsistent and different guidelines. Even the CDC, who's made some of the decisions labeling the techniques that we do and the procedures that we do in the pulmonary function lab as aerosol generating, many of them, there's no real good science, and even the CDC suggests that that's probably true. The evidence is very limited. A perfect example of some of this variation in guidance is the time after a COVID positive. My medical director and I were researching this because we're seeing a lot of patients now who have had COVID. We have a giant grant funded looking at the permanent or more permanent types of lung diseases that we see, and to try to document the type of lung disease that the patients that have had COVID, at least our study is looking at people that were intubated that had COVID, and we're trying to look to see what kind of lung diseases and identify that. Anyway, the European Respiratory Society in a very early statement said, wait 30 days after infection. This was a very early statement, one of the first ones that came out. The statement that just came out, July 14, 2020, ATS says wait 10 days. My infection prevention department said, Ed, we're asking everybody for everything else to wait 21 days. Can we just do that for spirometry and pulmonary function testing? And so, of course, I agreed. 21 days is somewhere between 30 and 10, so I figured, why not? So at the University of Minnesota, we're waiting 21 days after infection before. Also, the use of HEPA filters or not. Big debate on that. European Respiratory Society says HEPA filters no. ATS says yes. And then our air exchange people say that adding a HEPA filter, although it's a scrubber, it scrubs the room, it makes the room cleaner, doesn't decrease the air exchanges. And I'll talk more about that in a minute. So why are we concerned about spirometry during COVID? Well, spirometry is a forceful maneuver, as you know. You're asking the patient to take their biggest, hardest breath, blow and blast as hard as they possibly can. Spirometry has been listed as an aerosol generating procedure, an AGP, right? Before COVID, I didn't even know what an AGP was. It's an aerosol generating procedure. It's sort of, for some of our labs, it's become the new 4-letter word, although it's only 3 letters. In a pandemic spread by aerosols, the CDC has mandated that all aerosol-generating procedures be done in a negative pressure room, preferred, or a HEPA-filtered space with appropriate wait times. A negative pressure room is defined as it has a minimum of 12 air exchanges per hour. That means that the air in the room gets exchanged 12 times every hour, and that is vented outside. It's also important that when you open the door on a negative flow room that the pressure inside of the negative flow room is less than the outside pressure. So air runs into the lab when you open the door. What that does is that if a patient has been coughing and has been exposed to an aerosol generating procedure and there's COVID in the room, it doesn't then go out into the lobby. That's the idea. And then this thing here, this next bullet point that I'd never heard of before either, air exchanges per hour, or AHC. The air exchanges per hour determines wait times. And it's really important if you have a busy lab and you want to do a lot of spirometry tests. That's the time before the next patient can enter the same room. Now, it says here on the slide that the wait time chart's on the next slide. It's actually a little later in the presentation, so we'll look at that. The air exchanges, now a normal clinic room has about 4 to 6 air exchanges per hour. And so the wait time is directly related to how much and how soon the air turns over in that lab or in that procedure room. Also, CDC has listed all aerosolized therapies, nebulized treatments, as aerosol generating procedures. So even if you're going to give an albuterol neb, I'll talk more about that later. We've got some guidelines on that as well. Even if you give an aerosol neb, something like a nebulizer, an albuterol neb, you have to do it in a negative flow room, and the precautions are the same. Well, it kind of makes sense that spirometry would be an aerosol generating procedure. In order to do it right, they have to take their deepest breath. Now, in some patients, especially pulmonary fibrotic patients, idiopathic pulmonary fibrosis, the breath in causes them to cough, that forceful breath in. Then you're telling the patient to blast as hard as they possibly can and to blow and squeeze and get out all their air. Well, in patients that have airflow obstruction, emptying the lungs all the way down to residual volume usually will trigger a cough, especially in our COPD patients and our cystic fibrosis patients. And so they cough, and there's no doubt about it. On our research on particulate, coughing is what spreads the most particulates, especially the particulates of the size that could carry a virus. We're talking about particulates that are less than 5 microns in size. Also, spirometry traditionally was never carried out in negative pressure rooms. Patients can't wear a mask. Depending on the spirometer, the healthcare worker must be in close proximity to the patient. The American Thoracic Society and the European Respiratory Society both agree that filters should be used on all spirometry devices, bacterial viral filters. The issue is the patient's instinct is to pull the mouthpiece out or the filter out when they begin to cough. It's just a natural instinct to try to get something out of your mouth if you go into coughing. And so that becomes a problem. The American Thoracic Society says we need to know the prevalence in your community. In high prevalence areas, only essential tests or not to do the tests at all. This was a guideline that came from Minnesota about going back to school. In low prevalence rates, 0 to 9, I couldn't find, ATS didn't state or didn't mention what's high or low prevalence, so we pulled this out of something that was published in Minnesota. Low prevalence is a 0 to 9 per 10,000 over the last 14 days. Medium prevalence is 10 to 49. And high prevalence, these kids can only go online school, or distance learning as we call it, if they have more than 50. The community new case rate should be consistently low and have a downward trajectory for at least 14 days before resuming elective clinical services. This is right out of the American Thoracic Society. They also make a statement on that same statement. These statements are included in the links below that Jill told you about, so you can bring these into your own lab and read them. The ATS also made the statement that transmission of the SARS-CoV-2 is a dynamic process, and therefore it is likely that the prevalence of COVID-19 in the community will wax and wane. this impact on the institutions needs to mitigate this. Operating procedures should be frequently assessed and modified as necessary. My lab was designed as a negative flow room, and in all of our community here in Minnesota, I was one of the very few labs that were still open throughout the pandemic. Matter of fact, most labs are still closed. The American Thoracic Society and the European Respiratory Society are suggesting that we conduct essential PFTs only. And the American Thoracic Society gave some examples of what that is. Number one, they're talking about, in brief, in general, the diagnostics of idiopathic or complex dyspnea. If you don't know what's going on and the patient has shortness of breath, it's probably a good indication that it needs to be tested. Also, a guiding principle that my medical director and I have been using is, would spirometry lead to a change in therapy? As a general rule, if it's just a wellness check and the patient is doing very well, we probably would not do the spirometry test. And then they labeled 3-4 different things here: evaluation of transection or transplant or resection, monitor for transplant rejection. I mean, even for transplant rejection, we didn't do spirometry for a while, and my head of transplant said that, you know, Ed, I know some of these people are going into rejection, and I don't know who they are. The worry is that he knows that in these immunosuppressed patients, that being exposed to COVID would probably kill them. And so again, it's a risk versus benefit ratio. Some of these patients might be going into rejection, but the chance of getting COVID would be a risk. And obviously monitoring patients for drug-related pulmonary toxicity like amiodarone. The American Thoracic Society suggested some form of a grid like this, where you have community low prevalence of COVID and community high prevalence of COVID. If you don't have a diagnosis, you're going to consider doing the spirometry. If you have a confirmed diagnosis and there's a low risk of disease complications, in other words, it most likely will not change a medication, probably delay the spirometry. If you have a low prevalence and the disease is confirmed, the patient has a high risk of complications, like in this case, of somebody that has the possibility of going into lung transplant rejection. Then, of course, we would consider doing spirometry. High prevalence, if there's no diagnosis, you're going to probably refer to a pulmonary lab that has a negative flow. And that's a problem, because most pulmonary function labs are not designed as negative flow. They never have been in the past, and it's never been a requirement. It will be in the future, I'm sure. And then, of course, some sort of a matrix of a grid to decide if we're going to do. I think this will come more evident to everybody once we begin and we do some of the case studies. Here's our first number case.
Hello, my name is Kathy Mosley, and I'm going to go through our first case. I'm a master prepared nurse and from the office of the American Lung Association in Albuquerque, New Mexico. This case study number 1, Dr. Jones has an asthma patient coming in, child visit. 10-year-old Elliot has not had spirometry for 2 years. Elliot is doing well on current asthma medications, and his asthma control test score is 22. Dr. Jones would like to know if the prevalence would be appropriate for this patient to receive his routine spirometry check. And you can see the prevalence in the chart below. Goes from 0 to the highest is at 35, and the prevalence is going up and down over the last 2 weeks. This demonstrates how these particular counties look in relative prevalence to the rest of the state. And so the county this child is from, where Dr. Jones is, would be the second county from the top in bright red, indicating a historical high prevalence, and also in the map on the right, a current high prevalence.
Thank you. So I would like to invite participants to answer the question on the screen. Would you conduct spirometry on this patient? Yes or no? I'll give it 3 more seconds. And let's look at the results. 100% indicate that they would not conduct spirometry on this patient. Ed, would you like to respond?
Yeah, I mean, this is now the NEAPP would suggest that we should get a spirometry on our asthma patients every 2 years, and it's probably time for this patient. But their ACT, asthma control test, is looking very good. The patient really isn't, and there's a moderate, according to our guide, a moderate between 10 and 35, a moderate prevalence of the COVID in our community. So it looks like most people, that was a pretty good one, and everybody seems to, for the most part, get it correctly. Very nice.
Great. Kathy,
and
to you.
Case number 2.
Ed, I'll go ahead and read case study number 2 to you. Whoops. I'll take control of the slides here. 8-year-old Johnny from Colfax County, New Mexico, has unexplained shortness of breath and trouble sleeping due to cough over the past 2 months. He has a negative symptom screen for COVID-19, no fever, and a negative COVID-19 test within the last 48 hours. He lives in a county with continually low prevalence for COVID-19. Johnny has no previous diagnosis of asthma. He was sent home from the ICU with albuterol, but it has not helped. Excuse me. And at the bottom of the screen, you'll see the recent prevalence rates in Colfax County, New Mexico, related to COVID-19. If you look at this picture, you will see that Colfax County is, if you go from the left across the screen, moving right 4 counties, and then down 1, you'll see Colfax County in bright yellow. So asking participants, would you conduct spirometry on this patient? Yes or no? And let's take a look at the results. 100% said yes. Ed, would you like to comment?
Absolutely, I would agree in this particular situation. I mean, we have a new patient, we're not sure. I mean, even if the spirometry was negative and it showed a perfectly normal spirometry and no response to bronchodilation, we would want to find out why this kid's short of breath, right? And why he's coughing all the time. So I absolutely agree. Low prevalence, unknown diagnostics would lead me to saying yes, totally appropriate. We should be moving forward with the diagnostics on this patient.
Thank you. Kathy, would you like to read number 3?
Case study 3. 64-year-old African-American male, lives in rural area, was diagnosed with COPD, age 57, placed on Symbicort 2 puffs twice daily, and albuterol nebs or inhaler PRN. His annual spirometry tests have remained steady over the past 4 years, with age-appropriate declines. Patient represents today with complaints of increased wheeze and dyspnea when walking any distance, needing to sit and rest at frequent intervals. The patient is taking prescriptions as ordered and states he's using albuterol neb several times a day, most days over the past month. Patient has no fever, and vitals reveal slightly elevated blood pressure, heart rate 90, respiratory rate 24, oxygen 91%, on room air at rest. His COPD assessment test, or CAT, result is 30, which is high. And his MMRC, or dyspnea score, is 2, which means he walks slower than age group or has to stop when walking on level ground at his own pace. He hasn't been out much, and his daughter began bringing him his groceries.
Thank you, Kathy. And let's see what everybody would do. Participants, would you conduct spirometry on this patient? Great, and let's see what individuals' answers are. We have a mix this time. 2/3 would say yes and 1/3 would not. Ed, would you like to comment?
I would love to. Okay, now these are getting to be more fun, right? So spirometry on a known COPD patient, most studies have suggested it rarely helps us because usually in somebody with fixed obstruction and COPD, their spirometry is always abnormal and significantly low, right? Whereas in asthma, right, it bounces up and down. And of course, when it gets down, they're going into an exacerbation. But spirometry in a COPD patient is generally low all the time. Matter of fact, the new GOLD criterion, 2020 GOLD criterion, we no longer use spirometry to stage the medication therapies. We use symptoms, right? I would look at this patient that they're on an inhaled corticosteroid and a long-acting bronchodilator. The GOLD criterion would suggest if they're using their albuterol real heavily, that we should put them on a dual bronchodilator. So in other words, we should probably add a LAMA, regardless if we do spirometry or not. A LAMA-LABA therapy will increase the amount of bronchial dilatation in most all COPD patients and hopefully would give this patient some symptom release. I might not do spirometry on this patient, but I certainly would consider doing a 6-minute walk. A resting O2 saturation of 91%, and the patient can't walk on level ground without having to stop to rest would suggest that he's desatting. And so instead of doing spirometry, what would probably be not as much diagnostic, I would go ahead and step them up in therapy and give them a LAMA. I would do a 6-minute walk on the patient and see if they desat on oxygen or desat their oxygen levels during ambulation, and then would suggest giving the patient oxygen during the day, during ambulation, and maybe do a sleep study and see if they need oxygen at night.
Thank you, Ed. We had a question come in the Q&A box that I'll address to you before Kathy moves on to our next case study. Dr. Gail Bratman, a pediatric pulmonologist here at Hennepin County Medical Center, submits a question to you. What about asthma and COPD overlap syndrome? Would you consider, how would you deal with this, and would you conduct spirometry on a patient that you suspect of asthma and COPD overlap syndrome?
Dr. Bratman, always the hardest questions of all. Anyway, in the overlap syndrome, they have an asthmatic component that we're trying to manage, as you know. And so depending on what therapy I had the patient on, if I was already on maximum therapy, if I was on dual bronchodilators and an appropriate amount of inhaled corticosteroids, I probably wouldn't. But if the patient was on lower doses or not on an inhaled corticosteroid, I probably would go ahead and do the spirometry on the patient that has the combination asthma and COPD overlap syndrome, because I'm wanting to see if that asthma component is really kicking in. It's these people that have this overlap syndrome that seem to be the more brittle type of COPD patients that are in the hospital a lot and are spending a lot of time in the hospital. So I'd want to for surely want to see what's going on with this particular patient and make sure to try to keep them out of the hospital. Thank you, Dr. Brotman.
Kathy, would you like to continue on with case study 4?
Case study number 4, a 53-year-old male who lives just outside a metro area was diagnosed with moderate persistent asthma at age 31. He takes Advair 550 twice daily, Spiriva daily, and Singulair daily. This patient is an elite athlete. This is a regularly scheduled asthma follow-up visit. His biannual spirometry tests have been normal, and his exhaled nitric oxide test usually is around 40. His ACT score today is 19. This patient is a good symptom tolerator and reports that he wakes up once or twice a month due to coughing. He takes albuterol prior to his daily exercise. The patient lives in a community with moderate COVID prevalence, but the clinic where he sees care has a high COVID prevalence.
Thank you, Kathy. Let's see what our participants say. Would you conduct spirometry on this patient? And participants say, no, they would not conduct spirometry on this 53-year-old with moderate persistent asthma. Ed, do you have any comments?
Oh, I always do. This one I'm a little bit more of a fence sitter than it seems like all of our participants are. He was diagnosed with moderate persistent asthma when he was 31. But he's on medications which suggest that he has severe persistent. He's on the highest dose of Advair. He's also on an add-on of a tiotropium product, which we usually reserve for patients that have more severe asthma. And in this particular case, he's a symptom tolerator, right? Symptom tolerators basically sometimes can get in a lot of trouble, right? Before they report of having trouble. This one I'm a little bit more of a fence sitter on it. I guess I would, if you clinician would know this patient, and I'm sure his clinician does know him very well. And if he's one of these brittle asthmatics that can fall off the map very quickly, I might want to do a spirometry. Obviously, his ACT is just barely abnormal. Usually we consider 20 as normal. But anyway, there's no absolutely right or wrong answers to this, and there's always more to the story. Thank you. That's a good one.
Thank you, Ed. We're going to have another poll of all of our participants. What precautions is your practice currently using? And you can select all that apply. When you're conducting spirometry, you're not conducting spirometry testing. Do you screen all patients prior to a spirometry test? Do your technicians wear full PPE? You conduct spirometry in a separate room? Do you disinfect after a spirometry test? Please select all that apply. And let's go ahead and see what our participants answer to this question. And what we find out is our participants are screening all patients prior to a spirometry test. Technicians wear full PPE. Many or most are using a separate room, and they're disinfecting after a spirometry test. Ed, I'd like to turn it back to you.
Thank you, Jill. Well, basically, following the precautions for different healthcare professionals, we have to keep in mind social distancing, both in the laboratories of our staff members, but also out in our waiting areas too. Since COVID hit, we're testing the patients by themselves. In the past, we would have a family member sometimes would come in, or like in our pediatric lab, we would always have the parents come in, and no longer we always have the child. If the child's old enough to participate in the spirometry maneuvers by themselves, we have them come to the lab by themselves. All of the staff are wearing full PPE. We wear an N95. We've been wearing a surgical mask over our N95s to protect them because we use the same N95s all day. We use a face shield because spirometry induces cough. Probably the face shield is a really important thing. Gowns and gloves. In the new world of COVID, what we're doing is we're asking the patients, and I have a slide showing you this in a minute, asking the patients to blow or face away from the technician doing the test. We actually turn the chair away from us so that it's not facing the staff. In the old days, we used to be in very close proximity to the patient. We had the patient looking at the computer screen. We were looking at the computer screen, but now we're actually turning the patient away from us. So if they cough, the cough stream goes over. We're encouraging and teaching good cough etiquette. We have a big poster in front of each patient that shows cough etiquette, and we have tissues ready for the patients right in front of the patients. We're also fitting all of our PFT labs with clear plexiglass barriers, also known as sneeze guards. Other key component that the infection prevention team and I have been working on, generally in a PFT lab, we would see all different kinds of things like nebulizer compressors and disposables and maybe a MIP and MEP meter and different things like that were sitting in the lab because those are the kinds of things that we used all the time. Now in the COVID type of world, anything in a patient's room that's being done for aerosol generating procedures, all unnecessary equipment, furniture, all the items in the room have been taken out so that the room is very Spartan and free of everything. We're asking the patients to wear masks in the lobby and between maneuvers. We keep the procedure room's doors closed, except for when entering and leaving. This is another example of some of the inconsistencies that we see. How long should we wait after a COVID infection? Well, this is an earlier study that was an early publication that came, and these publications, again, are included in the links. The patient has COVID infection, no spirometry or PFTs until 30 days afterward. ATS now just recently recommended 10 days after being symptom-free, fever-free. And our infection prevention has suggested 21 days. And this is all inclusive aerosol generating procedures. You have to wait 21 days after COVID symptom-free, after fever-free.
Thank you, Ed. Let's ask another question of our audience. What PPE do you have available in your practice? And please select all that apply. You do not currently work in a clinical setting. You have gloves, face shield, gown, cloth face mask, N95 face mask, gloves available, or maybe you do not know. Please select all that apply. We'll give it about 5 seconds for everybody to indicate their choices. And let's go ahead and look at what the responses say. Why don't I turn it over to you, Ed?
Okay. Yeah, great. Looks like most people are using pretty much full PPE. Some have cloth face masks. We're using N95s during our infection prevention requires N95s for any aerosol generating procedures. Matter of fact, we were told that we can't do it unless we have an N95 on. This is a cartoon that was done by Val. She works for the American Lung Association as well, kind of showing you the idea of what the old days was. We have patients coming into the laboratory. We're doing the spirometry, and other staff members, nobody ever wore a mask. Staff members were kind of hanging around, and there was no social distancing. And this cartoon is showing more full PPE, right? And more distance between us and distance between the patient and us. And of course, the increased wait times and things like that. Move on to our next polling question.
Thank you. Does your PPE supply impact your clinic's ability to conduct spirometry? Yes, no, or I don't work in a clinical setting. Does your PPE supply impact your ability to conduct spirometry? And let's see what the responses say. About 1/3 of the participants indicate that personal protective equipment is impacting their ability, and 2/3 indicate it does not impact their ability to conduct spirometry.
All right, interesting. Who would have thought that a simple albuterol neb that we would be gowning and gloving and face masking and N95, something that me as a person who's been directing pulmonary labs for 30 years, albuterol neb was always just a knee-jerk reaction. Anybody who wheezed, that was struggling in their respiratory, labored breathing, we would offer a neb. Some of the labs, the CDC actually listed aerosolized meds as an aerosol generating procedure. Some labs have suspended all bronchodilation during COVID, no nebs, no BDs. Since we do a lot of pentamidine inhaled antibiotics, we have to do nebs because many of these patients, their life depends on getting their antibiotics, especially the patients that are on pentamidines, that usually because they've failed all the other oral meds. The American Thoracic Society and the European Respiratory Society are recommending moving away from nebulized BDs, using MDIs with spacers for bronchodilation instead. I have another slide with our protocol that will be coming up soon. Extreme caution is good, but I think the CDC was acting with extreme caution because there really is no data that suggests doing an albuterol neb or any neb treatment, the patient's just breathing normally, that there's any aerosolization of a virus. Anyway, a 2012 review of aerosol generating procedure conducted that there was no significant evidence of transmission risk related to nebulizers. This was from the SARS outbreak in 2012. SARS is a similar coronavirus, although, and you can read the study here if you like, although we never know exactly, each virus is slightly different. We've had a lot of trouble in the pulmonary labs. At the very beginning of COVID, there was a huge shortage of MDIs, even though European Respiratory Society and the American Thoracic Society was suggesting that we should switch to MDIs. We couldn't get them. They were all being used and all being used up in our COVID wards in our hospitals. They're on now. We have a nice supply of MDIs, but we can't get nebulizers. We have a huge back order of nebulizers and filtered nebs, and that has forced us now to use pretty much entirely MDIs, which maybe it's a good thing during. So don't you love a pandemic? So the availability of things actually has changed what we do. What we're doing in my laboratory is that if nebs must be given, I ask my staff to leave the room when the aerosol therapy is running, just in case it is aerosol generating. In other words, we get it all set up, we turn the neb on, we hand it up to the patient, we tell them as soon as we leave the room, put it in your mouth and begin your neb therapy. I'm also putting exhalation filters on all of our nebulizers. In other words, they're viral bacterial filters, so when they're breathing through the neb, Everything that comes out of the patient through a one-way valve goes through an exit filter, a viral filter there too. Also, PFT labs have suspended all different things like bronchial challenges, methacholine, mannitol challenges. Mannitol is a type of bronchial challenge. Exercise challenges. According to the American Thoracic Society, these are considered high risk, and that we should hold on these particular types of therapy or these particular types of diagnostics exams until the pandemic phase is over. This is the meter dose inhaler that I came up with myself, and this is what we're using in the pulmonary function lab at the University of Minnesota. This has always been a no-no, I've been told by my pharmacy. If the patient has their own meter dose inhaler with them, we ask them to use them. Now, in the past, it was always frowned on by my pharmacy department because generally this is discouraged in healthcare because we never know where it's been. That meter dose inhaler could be years old and might be expired. It could have been sitting on the dashboard of their car in hundreds and hundreds of degree weather, or maybe it was frozen. In Minnesota, that's certainly a possibility. I've seen some people pull MDIs out of their pocket. I saw one, he was a great guy, an old farmer guy. His hands were always all greased up and dirty all the way down to his fingernails, and so was his MDI. We supply the spacers for the MDIs, and we watch for and teach good inhaler technique if the patient is using their own. If the patient's not using their own inhaler, we've been approved to use multi-use MDI protocol by our pharmacy. Generally, we're not allowed to use multi-use because of Joint Commission, and so we always use ampules of nebulized therapy. And what we're doing now to try to use the MDI, which would be less aerosol generating, spacers are fitted with a one-way valve. This is what's preferred. That way the patient can't blow into it and contaminate the MDI. Spacer is always single use. We throw them away after every patient. Staff holds and activates the MDI after the patient begins their breath in. In other words, the patient never holds the MDI. These are the ones that we're using for multi-use. My infection prevention team says this is okay, and if you do this, as long as the patient doesn't touch the MDI. The staff then cleans the MDI canister and the activator with whatever approved SANA wipe is available for that day. We've gone through many different types of SANA wipes. They're constantly in short supply, and we keep getting trained into new ones and different ones as the shortages. The pharmacy is requiring me to, after we open the multi-use MDI, it's tossed after 21 days. We also keep track of each time it's used if it does not have a counter. If it has a counter, we make sure that we don't go over the 200 puffs. Of course, we need significant disinfection before and after the test. If you have the ability to use a separate room in your primary care department, we wipe down the spirometer and all the cables and all high-touch surfaces with sanitizing wipes. This is why it's so important that we have a very sparse room, because anything that's within 6 feet of the patient doing an aerosol-generating procedure needs to be wiped before the next patient can come in the room. Now, if you're changing the pneumotachs or internal parts of the spirometry equipment, you need to recalibrate the equipment after decontamination if it's appropriate for the manufacturer. We always use a filter with our spirometers. Now, there are some spirometers that don't have filters, and all of those spirometry companies are racing around to figure out a way to get a filter that works with their product. The air from the spirometry room should be exhausted directly to the outside. That's what a negative flow room. Some of my office spirometry people are saying they're opening all the windows. I think that's a great idea. Anything to increase the ventilation in the room. And then you close the door and let the room air be exhausted. This is a typical place. This is where we do intake in primary care. I have taught spirometry courses for many, many years. And I've always taught them to just make it another vital sign. In other words, there's a blood pressure cuff here, as you can see, the height and weight device here. We're measuring people's temperature. And I used to always tell my attendees of my spirometry courses, if they're coming for a respiratory problem, asthma or COPD, you just do the spirometry right there where you do the intake. I want you to notice how close the two chairs are next to each other. We have the calibration syringe and a spirometer on the table there, along with all the other kinds of things that we use for intake. This is the old days, right, before COVID. This is where we used to do the spirometry fairly routinely, especially in our primary care centers. This is the new laboratory. It's a negative flow room. We notice that we have the blue infection prevention keyboard, which can be wiped, turned off, and wiped with the biosanitized wipes, right? The blue keyboards, right? The same ones that we use in the ICUs. Notice that the patient and the staff are significantly separated apart from each other by about 6 feet. All of the disposables are inside Rubbermaid plastic bins so that the patient can't cough on something that you're going to use on the next patient. The computers and all the different kinds of things that don't need to be sitting on the table are under the table, right? There's Kleenexes available. This is the air exchange per hour chart. This is the wait time after aerosol generating procedures. Spirometry and nebs are considered aerosol generating procedures. This is the wait time after the patient leaves. You need to keep the room closed until a specific length of time has elapsed on the air exchange. The air exchange rates, basically what happened is I had to have we hired a person to come into all of my laboratories throughout the entire University Fairview system to measure the air exchange ratios. Basically what they're doing is they're measuring the amount of air coming into the room, the amount of air that's leaving the room to get the air exchange, the ACH, right? And they're also measuring the pressure difference inside the room compared to outside the room. The goal is that when you open the door in a negative flow room, that the air flows into the laboratory. If the patient was coughing during an aerosol generating procedure, or you're doing an aerosol generating procedure, you don't want to, when you open the door, for that air to then escape into the lobby, just in case it might have COVID in the air. And as you can see here, the average clinic room is usually between 4 air exchanges to 6 air exchanges per hour. That's normal. That's normal for a normal clinic setting. The wait times are 46 and 69 minutes. Even for a negative flow room that has 12 air exchanges per hour, the wait time is 23 minutes. Now, if you don't know your wait time, the CDC is suggesting that the room should be closed for 2 hours. 2 hours is the maximum time necessary to clear the air and release the room for next use. It's just another example of the different recommendations. The European Respiratory Society suggests that this should be HEPA filters, not EPA filters. HEPA filters are not recommended due to the possibility of viral colonization of the filter itself. I was told actually that that's really not a concern if the HEPA filter is maintained as it's supposed to be. The American Thoracic Society says that there should be significant time allowed between patients to allow adequate room ventilation, and the exact amount of room of time will vary depending on whether the room is under negative pressure and whether there is concomitant use of a high efficiency particle filter or a HEPA filter. Our infection prevention people says it's all about the air exchanges. How fast is the air exchanges, regardless whether it's negative flow or if it has a HEPA filter or not. Both the American Thoracic Society and the European Respiratory Society suggest that start thinking about home-based spirometry and monitoring. And so we have a big committee at the University of Minnesota where we're looking at home-based for our lung transplant patients and also for our cystic fibrosis. The Cystic Fibrosis Foundation has given us 40 home-based spirometers to give to our cystic fibrosis population, and we're trying to decide who best could use these type of devices. There's some kind of cool stuff. There's phone-based spirometry, and there's apps available where the patient has different ways that they can blow into their phone and it Bluetooth from the spirometer to their phone and gives them an idea of what's going on with their lungs and tells them their FEV1s. The issues are poor reimbursement for home spirometer. The home spirometer companies that charge a fee for the devices, the home spirometers, and also there's a fee for the data trending service that's not fully covered by the reimbursement that we're getting for home spirometry. Also, spirometry is a very dynamic maneuver. Anybody who's done spirometries before understands it's really hard for patients to master this. They have to take their biggest breath, they have to blow as hard as they can, as long as they can. And if they don't do all of that, basically suboptimal maneuvers are pretty much meaningless and cannot be interpreted. Generally, to get good spirometry, especially in people that are new to doing spirometry, the patients need to be coached to meet the ATS and European Respiratory Society criterion. There's also a problem is my doctors all want to have this go into the EMR. Home spirometers do not interface with the EMRs, with the medical records, and so the data entry is laborious, and it has to be hand entered from outside, or the doctor has to log into an outside service, into some sort of a cloud-based service to look at the trend for that particular patient.
Thank you, Ed, for your formal comments and remarks this afternoon. We do have a number of questions coming in through the chat box. So thank you, participants, for submitting those. And Ed, if you have time, we're going to go through those. I think we have about 8 or 9. Before I begin answering your questions, I do want to thank VetraCore for their promotional support of today's webcast. So the first of the questions we have is coming from Omaha, Nebraska, and they're asking is if you are in primary care and you usually take the spirometer into the exam room where the patient is at, it could take 2 hours for enough air cycles to go through to safely occupy that room again. Are there other safe measures or things you should do to be able to perform spirometry in primary care that won't take up those exam rooms?
Well, that's a hard one, right? Well, you could get your air exchanges per hour measured. It cost me about $200 per room. They use a machine called an air balancer. It took them about 10 minutes to do the air balancing, right? And once you know that your air exchanges are, say, 4 or 6, or maybe it's 8 or something like that. Also, sometimes facilities can actually direct more air coming out of a particular room by changing things in the ceiling. I was told that in my pediatric lab that that's all they needed to do was to change some stuff, and that the air exchanges, when it was retested for the air balancing, it went from actually 6 air exchanges per hour up to 12, which decreased the wait time considerably. And so, you know, people have suggested to do these spirometry tests outside. That sounds fun in a nice climate, especially today. It's beautiful outside here in Minnesota, but it's probably not going to work very well when we have a 10 below weather. Very nice question. Thank you very much.
Great. Thank you, Ed. The next question comes from Jordy, and he asks, are you taking all of the same precautions if the patient has a negative COVID test within the past 48 hours?
Yes, absolutely. Yeah, we take all the same precaution on every single patient. You know, we're not taking off our masks or anything. We know the patient is COVID negative. There's false negative tests, false positive tests, and of course, a person could have there's a very finite window of when the testing needs to be done, usually between 3 and 7 days after infection for the test to become positive, the PCR test. And so what could happen is the patient is slowly building up, right, the viral in their body. You could have tested, and then 48 hours later, the patient has a negative COVID test. 48 hours later, they might be shedding virus. And so the optimum time. So I've been told by my infection prevention people and my infection prevention director that we treat everybody the same, as if the possibility that they have COVID. And the American Thoracic Society went on about that too, about, we have a choice of testing everybody, requiring a test before we do spirometry or not. And again, the American Thoracic Society says it's problematic either way. You should just test everybody, assuming that there's a possibility that there's COVID. A nice question. Thank you very much.
Thank you, Ed. Dr. John Sweet is asking a question, a two-part question. Would you consider the use of a peak flow meter and also exhaled nitric oxide in your exam room as an AGP?
Dr. Sweet, my old friend. Well, of course you'd ask a really hard question. Let's see. I would imagine, just off the top of my head, that a peak flow would possibly be an aerosol generating procedure. It's a forceful maneuver, and it could possibly, and there's really no way to put a filter, an exit filter on there, because it would affect the results. If you put a filter on the backside of a peak flow meter, it would increase the resistance inside the device. Now, the pheno measures, the patient is blowing slow during pheno, and that one, to me, although I'm not sure, it wasn't listed by the CDC or by the American Thoracic Society as an aerosol generating procedure. I would suggest that a pheno measure is probably low risk. And I would probably say that pheno would be more safe or less risk than certainly doing peak flow, or spirometry would be the highest risk if you wanted to put it on a continuum. Dr. Sweet, thank you for your question, Dr. Sweet.
Thank you, Ed. I have two similar questions coming in about, is it safe to conduct spirometry on a COVID survivor for research purposes? And if yes, do you have any specific guidelines?
Just the guidelines is that, we have 3 different guidelines, again, about how long we wait, right? The European Respiratory Society says wait 30 days after the patient has COVID. The American Thoracic Society says 10 days after symptom-free. Now, they're slightly different guidelines, right? Because one is 10 days after symptom-free. And our infection prevention, since they decided 21 days, right? 21 days for all procedures after COVID infection. So standard across the board for all different types of procedures. So what we're doing at the University of Minnesota is we're using 21 days. We actually are doing a research project looking at the lung. We're doing complete pulmonary function testing and bronchodilator reversal studies and 6-minute walks on patients that have had COVID to try to document what changes and how are we going to look at that particular lung disease, because the scans and my medical director suggest that there probably is some permanent damage on some of the patients that have had permanent lung damage, some of the patients that have had COVID. And so we're trying to document that. And so we wait 21 days, and then we go ahead and test the patient. Spirometry, full pulmonary function testing. Again, using all the precautions, right? Aerosol generating procedures, full PPE, everything, even though the patient has had COVID 21 days before. Good question. Thank you.
Thank you, Ed. A similar question to that, shortness of breath that goes out beyond 21 days for several months. Up to 3 months, they're having this lingering cough and shortness of breath. And so in those cases, should we delay the spirometry test because we might get an inaccurate diagnosis?
Oh, okay. That's a hard one. That's a very intelligent question because it's bringing in all different kinds of things. That's a hard one. And that's exactly what we see. Many of the patients that have come to my lab status post-COVID infection are still symptomatic. We've seen all different kinds of things. We've seen their asthma really revved up. Like in that particular case, I kind of really wanted to do the spirometry and the full PFTs because this patient was highly symptomatic, having lots of trouble with their breathing, and it just proved to be a big stir up of their asthma. We have other patients that showed a decreased diffusion, which is suggesting that there's a possibility that there's something interstitial going on in their lungs. I can only say what we're doing at the University of Minnesota is that after 21 days after COVID infection, regardless if they're symptomatic or not, we're testing them and we're looking at what's going on. I don't know if that's the right answer, and I'm going to immediately ask my medical director if I made the right answer. Thank you.
Thank you, Ed. Next question coming from Michelle. How many puffs of the MDI do you suggest for the replacement of a neb treatment?
The American Thoracic Society in 2005 suggested that we always give 4 puffs through the MDI. Now keep in mind, when you're doing a nebulized therapy, studies have suggested it's between 5 and 10 puffs through an MDI. So what we're going to want to make sure what we do is we want to make sure that the patient is getting bronchial dilatation. We watch the patient very carefully, make sure they're breathing in the med correctly, that they have a respective hold time of about 5 to 10 seconds. We wait about 30 seconds between each puff of the MDI. What we don't want is the provider to wonder when you're seeing a bronchodilator study that didn't show any reversal. We don't want the provider to be wondering, oh, I wonder if they got med. We want to make sure they got med. Now, as you all know, that the clinical dose is 2 puffs. But the American Thoracic Society did a bunch of studies suggesting that patients that aren't used to using MDIs many times don't get an effective dose. And so they suggested we always give 4 puffs when we're doing diagnostic testing. Great question.
Thank you. Another question. Ricky is asking, we do not have a negative pressure room in our primary care clinic, just regular clinic rooms. How safe, even with full PPE, is it for us to do a spirometry test in the clinic? Should we even consider it, or should we take some additional safety precautions?
Well, it's safe. I mean, multiple studies have suggested that even in our COVID wards, that the PPE is protective, right? And I'm assuming that you're doing some sort of a screening so that there's probably low prevalence in your area, but also the patient probably screened negative for fever and cough. Well, I shouldn't really say cough because our patients are coughing. Pulmonary patients cough a lot, so it's hard to differentiate between maybe a COVID cough and their normal, say, asthma or COPD cough. But anyway, it's safe to do spirometry for your staff members. What you want to make sure that you do is that you wait an appropriate amount of time for the room to air before anybody goes into that room without full PPE, right? You wouldn't want to room the next patient. If you don't know the air exchanges, you'll have to wait 2 hours. If you can hire the air balancer people to come in and measure the air exchanges, then you can use a less wait time. But it's safe. You can go ahead and do the spirometry as long as you have a significant amount of wait time between patients. Great question.
Thank you. We'll take a few more because there's some wonderful questions coming in. Holly asks, what about MIP testing and inspiratory muscle trainers?
Yeah, NIP testing and NIP testing, right? These are pressures, right, that we're measuring on the neuromuscular patients. And then I didn't think about that one. Now, they're not listed by the CDC as an aerosol generating procedure. And I think that the risk, again, with MIP and these different types of muscle training devices is probably low relative to, say, something like a forceful maneuver like a spirometry would be. It's probably unlikely that it's going to induce cough, in my experience. And I would say that it's probably a low risk, those particular types of devices. But they were not listed as one of the lists of the CDC of it being an aerosol generating procedure.
Thank you. Similar question related to aerosol generating procedures comes from Matthew. And the question is, Matthew did not believe that spirometry was originally listed as an aerosol generating procedure. Only nebulizers were. Has this been updated and now CDC is including both of them as aerosol generating procedures?
No, actually, I have not seen anything from the CDC, an update that adds spirometry. Our healthcare systems and our infection prevention people and our pulmonologists who have been researching particulates, actually how we listed it. It wasn't from the CDC. I think it was an oversight. They did say something in the CDC statement, though, anything that could induce coughing, which, of course, spirometry can. So I guess loosely, spirometry, right, is listed in the CDC, but not directly. Spirometry or pulmonary function testing is not. This is something that our own healthcare systems and also our infection prevention and our pulmonologist, including my medical director, have all suggested that it should be included, and so we included it as an aerosol generating as our own site. And I have had that debate with some of my outside medical directors and pulmonary lab medical directors that have said, show me where it's listed in the CDC. Well, I don't think I have to show you. We know that spirometry is a forceful maneuver, and we know that it generates cough. We know that cough and forceful maneuvers, right, aerosolize particulates, right? And so to me, it's sort of a no-brainer, even though the CDC did not, I think it was an oversight, did not list it.
Thank you. I will ask the final. Thank you. I'll ask the final question of the day, even though there's a number still in the inbox of questions. We are running out of time, and we will do our best to answer those questions after the fact. The question is, could you please repeat your recommendation on use of filters with screening spirometers?
You know, use of filters with screening spirometers. Now, most of those little handheld screening spirometers are basically just a little bit of a complex peak flow meter that also does FEV1s. Most of those are turbine type devices. And I do not know of a way to put a filter on a turbine device. We couldn't put it in the front or in the back of it because it would change all the numbers. If you put a filter, an exit filter on a turbine type device, the turbine would spin slower. And same thing if I put a filter device on the front of them. And so those devices I would not use to do spirometry unless they're single patient use only. These devices are like $100 to $160 or something like that. So it would be, you know, I would say that we wouldn't want to use screening type spirometers where you take a big breath, you put it in your mouth and you blow hard, right, during a pandemic, because there's no way to filter the air going through it.
Thank you. Ed, I would like to thank you this afternoon for your time and talent in conducting spirometry in primary care during and after COVID-19. I'd also like to thank all of our participants. We had approximately 350 individuals register for the live or on-demand webinar today. So thank you all to the participants for your interest and passion in lung disease and spirometry testing. On behalf of the American Lung Association, thank you all for your time today, and we are now going to end the webcast. Please remember that the webcast is available tomorrow using the same link how you accessed it today. Thank you and have a good afternoon.
It was my pleasure. Thank you, everybody.